Thank you, Mr. Speaker. The dental activity threshold has recently been raised to 95% of usual activity, which is another quarter-on-quarter increase to get us towards pre-pandemic levels of 100% of activity. But I fully recognise that before the pandemic, access to NHS dentistry was patchy, and the crux of this problem is the current NHS dental contract. So work is underway to reform this contract. Negotiations have started, so I'm limited in what I can further say on this, but I will update the House as soon as possible. One of the key pieces of work is through Health Education England, who set out a range of recommendations in their Advancing Dental Care Review, which will do a number of things, such as increasing the skill mix and scope of practitioners across dental teams, and we may be, while it require legislation to bring some of that work forward, they're introducing more flexible routes into dental training, and they're also doing some workforce modelling to identify the parts of the country with the biggest gaps, so we can establish centres of dental development in those areas. There isn't actually a list system for dentists as there are for GPs. Patients can see any dentist when they have a dental issue. That said, we have asked dental practices to update their availability for NHS patients on the website. I was looking at the website this morning to see availability across the country, and many dentists still haven't updated their availability. So I'll ask officials, particularly in her constituency, to update those lists so patients can access NHS dentistry more easily. The crux of the problem is that there isn't a shortage of dentists across the country. There's a shortage of dentists taking on NHS work, and the contract is the nub of the problem, and that's why we have started work underway to reform the contract, and there will be some short-term changes being announced shortly, and some longer-term reforms as well, which hopefully will help his constituents. He is correct that the units of dental activity payments are a perverse disincentive. So sometimes when someone needs more extensive work, their dentist is paid the same as say, for one or two simple fillings. And that is the nub of the problem, and that is something that we're in negotiations about at the moment. Part of Health Education England's review of the overall system of where dentists are trained and where they fill the gaps is being addressed in their Advancing Dental Care Review. And they're also working with commissioners at a local level to develop more opportunities in those places which we term dental deserts, where there is a lack of provision at the moment. Well, I'm sorry to hear the tone from the Honourable Lady. It is actually the 2006 Labour dental contract that we're working under. She may have missed that for the last 2 years, during the pandemic, dentists weren't able to offer any routine care, and we've slowly had to work that up to 95% of usual activity. And she may want to play politics with this issue. Perhaps she wants to talk to her Labour colleagues who run the NHS in Wales, where 6% of dental posts were lost last year. So before she lectures this side of the House, maybe she needs to get her own side in order. We've had many cross-party meetings with colleagues on the issue of dentistry, and many have raised constituency issues with me, and we have followed those up. The two things that I would suggest to him is firstly to speak to his local commissioners, because there is sometimes a problem with local commissioning of dental services, but I'm hoping he'll find now we're moving to 95% of usual activity, which is a significant change since last year, that his constituents will be able to access services more easily. Earwax services are the responsibility of local commissioners, who are responsible for meeting their local healthcare needs. And depending on the arrangement of the local area, services should either be undertaken at local primary care practices or referred to appropriate local NHS services. There is no national removal of earwax removal services. They can be commissioned still locally, and NICE guidance are very clear on the types of services that should be being commissioned. Traditional methods of manual ear syringing are no longer offered for safety reasons, but methods such as electronic irrigation or microsuction should be being offered. If his local commissioning group are not commissioning those services, I'm very happy to meet with him and them to discuss why not. He's absolutely right. There needs to be some consistency across the country in how these are being commissioned. And after questions today, I am taking this up with officials to see why this isn't happening consistently across the country. The government recognises that menopause services are needed to improve, which is why menopause is a priority area in our women's health strategy. We also recognise that it's often best provided in primary care, but some women do need some specialist services, and we are looking at this in our women's health strategy and also the menopause task force as well.